Hello, good evening, and welcome back. It's good to be back with you once again. This is our second webinar tonight, so I'm even more happy that we have some familiar faces here as well. I mean, familiar names at least. Thank you so much for joining once more. And as you can see, we do have another special guest, Dr. Emma Adsuar is with us tonight. Dr. Emma, how are you feeling tonight?
Perfect. I'm a little bit tired because I'm in Dubai, and in Dubai is 12
Yes.
midnight, but it's
It is
okay.
definitely late for you. So even I am even more happy that you still decided to be with us tonight and will present such an important topic for sure. So thank you so much. Okay.
Thank you
And
for inviting me.
yes, we are definitely happy to have you on board. And before we start with the presentation, let me just say that, of course, we are here every single day, as you know, because we want to support you, we want to educate you, we want to answer some of your questions at least. And as you know, my IVFNSS is just a part of European Fertility Society, and we will support you throughout the next few weeks as well. So as you know, we've had one week of the webinars already, and we are going strong with some more of them. There are plenty of topics to choose from. So as I've mentioned, tonight we will talk about standard fertility assessment, and this week we are definitely focusing on fertility assessment overall. So I'm very happy that you will be able to speak about this for us as well. And as always, remember, it is recorded and you will be able to watch this again. It will be available tomorrow on our website. And well, during the presentation or afterwards, go ahead and type in your questions. Dr. Emma will definitely answer them for you right after her presentation. And I would say that will be it from me for now. Dr. Emma, ready to start?
Yes, ready to
Wonderful.
go.
Glad to hear this. Let's go ahead with the presentation then. Thank you.
You're welcome. Okay, so let me check this. Okay, okay, perfect. Okay. So, what do we understand for fertility assessment? Is what are you going to face when you go in the first time to the consultation of a fertility doctor, right? The most important thing is to describe what is fertility. Okay, 85% of the couples, okay, are able to conceive after 1 year of regular and unprotected sex intercourse, right? When this doesn't happen is when we have to consult the doctor, right? The infertility increases progressively with the woman age due to the decrease of the ovarian reserve and the deterioration of the oocyte quality, okay? So for that reason, we recommend those women who are more than 35 years old or who have any kind of diseases like, for example, polycystic ovarian syndrome, hypothyroidism, or another kind of disease that can affect fertility, to visit the doctor before 1 year, okay? If you realize in the first slide, I said 1 year of unprotected sex intercourse, right? But in some specific cases, we reduce this time in 6 months, okay? This is to be really, really clear. Okay, why I said here infertility versus sterility? Because in some countries, like in Spain and Spanish, we differentiate not being able to conceive. This is called sterility, with being able to conceive but not being able to have a life born. Okay, this is the difference between those definitions. Okay, so to understand this, we have to check which are the causes of infertility, right? Before, long time ago, like some years, we used to think that women's factor was the most prevalent, but nowadays we have been proving that it's more or less equal, male and women's factor, right? So 30% of the causes comes only for the men, okay? And the rest of the causes is like a mix between women and men. but there is like a 20-25% of the causes that we don't know exactly what is happening. At least we don't know that with all the information and with all the techniques that we have nowadays, but most likely maybe in 10 years, in 20 years, we will be able to diagnose those people who were not able to conceive nowadays. So, what to expect when you visit the doctor for the first time, okay? I would like to remark here that it's really, really important that in the first visit, both the male and the female, should visit the doctor. Sometimes we realize that when we are in the consultation, we only see the female part of the couple, right? And this is wrong, because all the information that we could acquire in the first visit is really, really important, okay? Because it will guide us for different diagnoses, and it would guide us for the next treatment of procedures to do, okay? So what to expect? The first thing, we are going to concentrate now on the female, right? The first thing the doctor would do is the clinical history, right? That is called the anamnesis. And with the anamnesis, with some questions, we can, as I said, we can start having like an idea why that couple is having a problem trying to conceive or trying to have a life born, right? So we start with family history. Why is really important, the family history in the female side, okay? Because some women, for example, they have a history of premature ovarian failure, okay? So it's really important that they would know what time the mother, the sister, the aunt, if it's possible, had the menopause, okay? Because some of them, they had the menopause really early, like before 40 or in the early 40, okay? So that will guide us, or will give an idea that maybe this patient can suffer for this condition. Okay, so what else is really important? What are we going to ask also? We are going to ask about the personal history. Okay, the personal history is a mix of some questions as the diseases that the patient is suffering from, hypothyroidism, polycystic ovarian syndrome, autoimmune disorders. Why this is really important, okay? If we have, for example, a pathology focused on the thyroid, that can make all the axis, the hypothalamus, hypothyroidism, to be affected, okay? So sometimes some small pathologies in the thyroid can affect the ovarian function. So what do we have to do? We only have to treat this part, okay? To be able the whole axis to work, right? Okay, with the polycystic ovarian syndrome, it's more or less the same. As the name says, it's a complete syndrome. So once we target all the small aspects of this, most of the time the ovarian function will start working again, and those patients sometimes don't need more treatment, okay? More further treatment, okay? The surgeries that the patient has had, for example, if they had appendectomy with peritonitis, for example. Why this is important? Because the appendix is really close to the ovary and the tube, okay? So sometimes if we had a surgery, really late surgery, the right tube and the right ovary can be affected. Another surgery that can affect the can reduce, for example, the ovarian reserve. It can be like, for example, a cyst, endometriosis, or a normal cyst, a dermoid cyst, okay? What can affect also, what is really, really important, okay, that we are going to ask, if the patient is smoking or drugs. Why? Because smoking and drugs has been proved to diminish the ovarian reserve, okay? Some some medication that the patient is taking can also affect the fertility, okay, or cannot let the patient to conceive in that moment, right? Okay, continue with the anamnesis, right? We will continue with the gynecological history. This is really important to know what time, when the patient had the first period in her life. This is called the menarche. Why this is important? Because it's not the same that the patient had the first period
Dr. Emma, can you hear me? Because right now the sound is breaking. Please let us know if it's only me, but I believe we cannot hear you at the moment, okay? So please let me know if you can hear me. Okay, sound is gone for you as well. Thank you for confirming. I will disappear for 1 second. So I will double check with Dr. Emma. So please stay tuned. We will fix it, I'm sure.
Okay, can you hear me now?
Yes, I can hear you right now, so I think should be okay. Yes, our patients
Okay,
for us as well, so should be okay. Go
okay,
ahead.
I'm sorry. Okay,
It's
so
okay.
I mean, did you hear everything? I mean, when did you stop hear me? In which slide? So if you need me, I can go back.
Yes, okay, we can go. That was the previous one, I believe. Just give me a second. Just a second. Let me just go here. Yeah, here.
Okay, here, right?
Yes, yes, that's the one for sure.
Okay, so what I was saying here that is really important, the clinical history, and the second step, the second thing that we will focus on, it will be in the personal history, in the diseases that patient is having, for example, hypothyroidism, okay, because these diseases can affect the ovarian function, okay, whether directly or indirectly. The hypothyroidism, for example, control the axis of the endocrinology of the patient. And if this is not working properly, the ovary is not going to work properly neither, right? You heard all this one. Okay, so you didn't hear the next slide, right? This one is the one that you didn't hear. Okay, perfect.
Yes,
Thank you.
sorry.
Okay.
Yes, correct. Got
Okay, thank
confused
you.
a bit, but thank you so much.
No,
Yes.
don't worry. Thank you, Alex. Okay, so what I was talking about the gynecological history is that it's really important to remember to describe the doctor, for example, the first time you had a period, right? This is what we call menarche. Why? Because it's not the same that if you had a menarche when you were like 10, 12 in a natural way than if it was induced, for example, at 17 years old because you didn't have it, okay? Because that can obscure, for example, genetic problem or like more deep problem that can tell us, of course, that we don't have, for example, too much ovarian reserve, or that we can have, for example, mosaisms. I will explain that later, okay? Also, it's really important, the menstrual formula, for example. It's not the same that the patient tell us that she has the period really regular, okay? Regular means that follows a pattern, okay? If a patient tells you that her period comes every 35 days, this is correct. This is regularity, okay? Because some patients, some women, they think that because they don't have like 28 days pattern, they are not regular anymore. Or they think that if they have the period every 28 sometimes, 30 another time, 26, okay, it's not regular. No, this is a regular pattern, okay? That means that you are not exact. But trust me, not every woman is really exact. So more or less, most of us, we have like 2 days above, 2 days down, okay? But more or less, this is important for you to understand, okay? Also, if you have pain during the menstruation, why? Because it's not normal. The menstruation doesn't have to come with a lot of pain. So if you have pain, that could be explained because you have a cyst, because you have endometriosis. This is another disease that can affect also the fertility, okay? Another question will be about the obstetric history, okay? If you had any kind of pregnancies, it's not the same. A patient who has not had any kind of babies or any kind of pregnancy, that another one that can have had at least one baby, or one baby with another couple, and then she changed the couple and they're trying to conceive for a while and they couldn't. And it's not the same also the patient who has had, as I said, miscarriage, or that she was pregnant before, but she did an abortion and then she's trying to conceive, okay? Okay. Then the second step after the questions will be the examination, right? The first thing that we are going to do is the general examination, to have a look, right? To have a look of the patient, to take the body mass index. As I said, everything can affect the fertility, everything can affect our general health, right? So obviously, we always recommend to be in this green side, okay? But it has been proved that patients who are in this area, okay, with obesity, okay, they have more difficulties in conceiving. So on those patients, we will try to organize a nutrition plan to lose weight rather before starting any kind of treatment. Because most of the time when they lose weight, okay, unless they have associated any kind of other disease, they can get back their the regular ovarian function, and they can get pregnant easily, at least easier, okay? The same happen with these with people who are really slim. Obviously, some people are genetically thin, so they are not going to face any kind of problem, okay? And neither here, right? But among the persons, the women who are facing issues trying to conceive, if they are too underweight or too overweight, we always recommend like to have a better weight before starting a treatment, a plan, right? Okay. Then after the general examination, we will go to the pelvis exam, right? So why this is really important? Some patients, for example, they have an hymen imperforated, for example, and they cannot have intercourse, complete intercourse. They think they are doing things properly and they are not, right? And also because as you see, with the hand and with the look, we can see some abnormalities, for example, to cervix, or we can We can diagnose, we can feel like a tumor in the uterus. We can touch something in the ovary, okay? And as I said, that can give us a kind of ideas, okay, why the couple is facing these kind of issues. Okay, which will be the complementary test that we can do in the first consultation, a scan. I mean, I don't know any woman who have gone to the gynecologist without having an ultrasound scan, which is really, really useful, right? But please don't forget that also the pelvic examination is really important, because sometimes the patient goes to the clinic and they only want the ultrasound scan and we forget about the examination. So once we use the scan, we can see the uterus and we can see the ovary, okay? We cannot see that patients think some of them they are mistaken, because they think that with the ultrasound we are going to be able to see the tubes and we are going to be able to see if they are working or not, okay? If the tubes, we can only see the tubes if there is an abnormality, okay? So we cannot see the tubes in the ultrasound, in a normal ultrasound. So, but what we can see in the ultrasound is the normal shape of the uterus. We can see if there is, for example, a fibroid polyp inside the uterus. We can see if there is a cyst in the ovary. We can see if as I said, if the tubes are abnormal, if they have fluid inside them, okay? That is called hydrosalpinx, for example, okay? We can also check the basal status of the ovary, okay? So if the patient, for example, comes for the first days of the cycle, we can also count. These are, I don't know if you are seeing here, these black sacs, okay? And this is a polycystic ovary, but for you to understand, these sacs contains the follicles. So in the first visit, if it's possible, otherwise we will arrange another one, we can count the follicles of the ovary, so we can predict the ovarian reserve, right? The second thing that we can do is a blood test. Sometimes we request the blood test in that moment and we ask the patient to come back another day, or sometimes it depends on, as I said, it depends on when the patient came. If the patient came in the correct moment, okay, we will extract the blood in that moment. So we will order like regular blood test to check the status of the patient, to check that the patient doesn't have anemia, doesn't have, for example, cholesterol. That doesn't affect the fertility, but we would like to have a look of the status of the patient, the health of the patient, okay? We will order also the blood group rhesus. Why we order this, okay? Because it's really important to have also this information, just in case the patient goes, for example, to egg donation or goes to sperm donation, right? Then the serology, HIV, hepatitis, syphilis, for one reason, okay? Because if we are going to undergo fertility treatment and we have to go into to surgery, I mean, not surgery exactly, okay? Even though we take the patient to theater, but if we have to manipulate the patient, or we have to store, to freeze the eggs, it's really important for us to understand that the patient doesn't have any kind of a disease, an infection. More or less, mostly is because of safety, okay? Then, this is like more specific for fertility. The anti-Mullerian hormone, that I know that you had a webinar, so you understand what it means. The anti-Mullerian hormone is going to give us information about the ovarian reserve. So the AMH with the FSH and LH and estradiol, those of these together with the ultrasound, it will give us information about the ovarian reserve, and also it's going to give us information about the prediction of the response of the patient if we start with the treatment. Okay, so it's going to allow us to calculate the dose of the treatment, right? Also, the TSH and prolactin, as I said, they are hormones that can affect the ovarian function. Okay, so it's really important because sometimes when we request, for example, the prolactin, we see that this hormone is really high, and only by diminishing this level, everything works perfectly, and the patient can be pregnant, can have a natural pregnancy without undergoing any kind of treatment, right? Then there are also some tests, another tests that we can order that are specific for recurrent miscarriages, right? For example, thrombophilias, so autoimmune disorders, but this is like much more specific. So for that, but this we will know, we only order this if we suspect, obviously. And how can we suspect? With the anamnesis, okay, with the personal and family history. Okay, in this case, it's like much more, the recurrent miscarriages is like much more personal. But for example, if the mother has had a diagnosed thrombophilia, okay, and we don't know anything about the patient, we can request blood tests to diagnose that thrombophilia in the patient, because sometimes they share, okay, the same disease, okay, without knowing. Then also the karyotype, okay. This is, for example, if the patient, the karyotype is the chromosomes that a person has, right? Okay, you know that women, we have 46 chromosomes XX, right? Men, they have 46 chromosome XY, right? So most of the time we don't request this test if the patient already had a normal baby, okay, a live-born baby without any kind of problem, right? In those patients who hadn't had any kind of baby, or they had a baby with problems, we request. Why? Because sometimes we can see that some patients can have like a mosaicism, okay, and for them, they look completely normal, they are normal, right? They don't have any kind of pathology. But if you have a mosaicism, or if you are a carrier or some disease in some gene, that can affect fertility, okay? And then it will lead us to whether ovarian donation, egg donation, or whether to biopsy the embryos before transferring, okay? So for that reason, it's also important, this test, in some cases, not in all cases. Okay, so I wrote here the cervical culture. I suppose that all of you do, you know what is the chlamydia. Chlamydia is a sexual transmitted disease, but nowadays we don't usually do it in all patients. As I said, it depends on the personal history. It depends on the information that the patient gave us at the beginning. Then we will go through this test or not. Okay, so as I said in two previous slides, if I'm not wrong, okay, I was talking about the ultrasound in infertility, in the diagnosis of some diseases. Sometimes with the ultrasound it's not enough, and we need to further test. Obviously, we are not going to do that in the first consultation, but we can request. If not in the first, in the second visit of the patient, right? That is called the hysterosalpingography. With that, we can see the tubes, okay? One important thing, we can see the tubes, but we don't know how they work, right? Sometimes we can see a normal tube, okay? But that doesn't mean that the tube is working properly. Or sometimes we can see a tube that we don't like, okay, by the look, but they are working properly. So this is only important when the patient has any kind of fertility problem, right? After, as I said, I remember it's really important in those patients who don't have any kind of problem after 1 year of sexual unprotected intercourse, okay? And patients who are about risk because of the age, because they already have disease, a basal disease, okay? They should wait only for 6 months, okay? So the rest of the patients, they shouldn't do any kind of test prior trying to conceive, right? So the hysteroscopy, as I was saying, is like a contrast that they insert a cannula in the cervix of the uterus, and they put a contrast in it, okay? And then we have like X-ray. So we will see the shape of the uterus, okay? This is the cervix, okay? This is the uterus, and we will see the tubes, right? Okay. Sometimes we cannot see, we see up to here. What does that mean? That this is blocked. So the tube is not open. So if the tube is not open, obviously the egg is not going to be able to go through the tube. Okay. Sometimes we see that in both tubes. So then we diagnose one of the problem, right? That is that the tubes are closed, so the egg is not going to be able to meet the sperm inside, right? So in those cases, obviously, we will recommend the IVF treatment. Sometimes we can see only one tube working, okay? Working, I mean, open. And that doesn't mean that we cannot try, for example, an IUI, right? An intrauterine insemination, okay? Another test that we can recommend, but is not a must, as I said, neither this one, is the hysteroscopy. The hysteroscopy is a camera that goes into the uterus, so we can visualize the uterus, okay, completely, okay? We cannot see, with this test, we cannot see neither the tubes, neither the ovaries, okay? Because some patients, they think that after performing this, we are going to be able to see the tubes. We are not, okay? We see the uterus inside. So here we can see if the patient has a polyp, if the patient has a fibroid that is blocking, it's not allowing the embryo to implant, or is not letting the endometrium growing perfectly. So we can, at the same time, we can visualize and removal of the fibroid, polyp, or whatever we see, okay? Sometimes we can see also additions, okay? In those patients who have had, for example, previous abortions, or who have had like sexual transmitted diseases sometimes, this is completely with like glue, right? Like adhered. And we have to open, break those additions, okay, in order to let cavity, a normal and regular cavity, in order to allow the embryo to be implanted, okay? Sometimes we can see also like a septum, it's like a wall inside, okay? And we can also remove that wall, and that will can obstaculize the pregnancy, okay? Then another test that we can order is the hysterosonography. This is really useful and is really, really easy, and is less painful than, for example, the hysterosalpingography. The hysterosonography is like a cannula with the same, this is an ultrasound, okay? So with the same ultrasound probe, you use like fluid, you enter, and with the same probe, you can see the uterus inside. So if you see here, okay, these are fibroid, okay? Obviously, this test is only diagnosed, okay? That is not diagnostic test. This is another diagnostic test. And this is diagnostic and therapeutic, because we can perform a surgery, we can remove everything that we find here, okay? Then What about the male? So, as I said, it's really important, at least in the first visit, the male comes with the female, right? Because it will facilitate all the procedure. So, as I said, it's really we will start with the anamnesis, with the questions, the family history, because sometimes they have like disorder in the family. Okay, they are carrier, that they are not going to have any kind of problem visibly, right? But that is going to be translated into diminishing of the fertility with the sperm. Okay, that maybe the sperm is not good enough. So the family history is really, really important in this case too. Then we continue the same, the personal history. Does this male have children with different couple? It was difficult to conceive. It was through IVF too. They have children with the same couple they are going out to the doctor with. They don't have any kind of children. Do they have diseases like hypothyroidism, cystic fibrosis, renal diseases? Because those diseases can affect also the sperm production. Okay. Did the patient had surgery as, for example, varicocele, hydrocele? Some of them, for example, they performed vasectomy because they didn't want to have babies anymore, or they didn't have babies, but they were sure that they didn't want to have any kind of offspring. And then they wanted to revert, and they thought that vasectomy is easy to be reverted, and it's not the case most of the times. What we have to do is we have to extract the sperm from the testicle itself. Okay, so this surgery is also important to be said, okay, in the questionnaire. And obviously, we cannot forget about the toxics, smoking, drugs, about the medication that the patient is taking. Some, for example, some male, they are taking corticosteroids or anabolics in order to grow the muscle, and that can be in detriment of the sperm production. Okay, another important factor is the lifestyle. Okay, because maybe the patient, the male, is really healthy. He doesn't smoke. He goes, for example, he's telling you, I'm doing a lot of sports, and then when you are asking, they are doing a lot of cycling, right? So it's really important for those males who are, for example, going every day like 2-3 hours in the cycling, okay? You should understand that the testicle, it can be, they can be impaired because of the increase, as a result of the increase of the temperature, okay? For example, for that reason, it's really important also asking the lifestyle of the patient, okay? Or if, for example, if they are sitting long times, it's the same, okay? Because the increase of the temperature in the testicles, it will translate, it will have as a result decrease production of the same, okay? But this can be reverted, so don't worry. This is not going to be forever. It can be reverted. The good thing about the sperm production, rather than the ovarian production, is that the sperm is continuous. Okay, the eggs of the woman is fixed. Okay, we are born with some number, and we will lose them as we are growing. Right, the men, unless they have a really important disease, this is like a dynamic production. Okay, so sometimes, for example, to give an example, maybe now in March, the production is not too much, but if we change the lifestyle, if we change toxic, in 2-3 months, it can be improved a lot. the same. The physical examination is really important. In this case, more than the underweight is more the overweight. As I was saying about the lifestyle, for example, obesity is not only that it's impairing the axis, the hypothalamus-hypophysis gonads, it increases also the temperature of the scrotum of the testicle, and with that the decrease of the production of the sperm and the quality. It's not only the number, it's also the quality. Okay, the genital examination is sometimes we can diagnose like a genetic condition only by looking the patient, some male, for example, who are really short, who have like some feature like women, they can have like underlying genetic condition that hasn't been diagnosed before. Okay, in a male, most of the time, when they visit the IVF doctor of the fertility, more than IVF, I would say like the fertility doctor, most of the time they are not examined in that moment. We will refer them to the urologist, okay? But for them, this would be the examination that the urologist will perform, okay? The genital examination is really important because sometimes we can feel that there is something in the scrotum, in the back that is surrounding the testicle, that is holding the testicle, okay? So it could be, for example, the hydrocele, and as I said, because of the increase of the temperature, can reduce also the production and the quality of the sperm. The varicocele is varicose veins, okay, in the vascularity, in the irrigation of the testicle, and the physiopathology, the way of, for you to understand, the way of affecting the sperm production is by increasing the temperature, okay? Then it can happen that, for example, the male doesn't have one testicle, doesn't have two testicles. It could be because of previous surgery, some cancer in the testicle, or because he was born like that, okay? So this is really important. Then, for men, obviously, we have also to perform some blood tests. As I said, in the woman, okay, in this case, the blood test that we order, unless we are suspecting like much more another kind of disease, okay, it's more for safety. Yeah, because you know that we will store, we will manipulate the sperm, so we need to be safe in both sides, okay? Just because we have to freeze the sperm, and if the patient has, for example, HIV, we need to make sure that this sperm is going to locate in well-prepared test tube, and is not going to infect the rest of the patients, okay? And because of us, because as a doctors or nurse, we with the manipulation, okay, we don't want to be infected neither, okay? This is more this is the reason in this case also. Okay, then we will request also the sperm test, okay? What will happen if the patient, for example, if the couple comes to the consultation and we see that, or we diagnose that the female has a polycystic ovarian syndrome? Should we stop? No, we should continue assessing the male, because sometimes, if you remember, in the second slide, if I'm not wrong, or in the second and the third slide, okay, there is like mixed causes, okay? So sometimes you see that there is a female factor, but you also see a male factor, okay? So here you can see the sperm test classification, right? So We recommend, okay, this is really important on those male who wants to conceive and are not getting it, okay? Why I'm explaining this? Because some men who have, for example, 3, 4 children, okay, if you check in the table, they will in the table will tell you that maybe they will have a problem because they are like or they have less quality, less quantity, the sperm don't move, okay, or whatever reason. But we have to focus only on those patients who visit the fertility doctor, okay? On those patients, if besides, we test any kind of problem in this is when we have to do a treatment, okay? I hope this is clear, okay? Because not all the men should perform a sperm test. You can find a lot of men who have like not quality enough having babies. Okay, so another test that we will request, not always, as I said, is the fish. Fish is like a karyotype, okay, but like more specific in the sperm sample. Why? Because sometimes we can see that, for example, the male has a normal karyotype, normal chromosome count, and everything is okay in his cells, but in the gamete, okay, they are not okay. Okay, they have an increase of, for example, Down syndrome, not Down syndrome, sorry, the 21 chromosome. This is the one that can lead into Down syndrome, okay? So in those patients, we will, if we want to use the sperm of the patient, we will have to do some tests before, okay? Before doing, for example, an IVF or doing an IUI. Or we can recommend an sperm donation in those cases. Okay, this is the last slide. The same as a female, we will request a karyotype. Why? Because sometimes we don't see 46 XY in a man. We can see like some mosaicism. Mosaicism, it means it's a mixed, okay? Or they are carrier of a genetic condition that is affecting fertility, and for that reason the female partner is able to conceive, but is not able to have a live-born baby, okay? So I think that's all. I know that it's a lot of information. Okay. If you have any question, so I already finished.
And wonderful. Thank you so much, Dr. Emma, for that thorough presentation, for sure, and for explaining all those details. Because, as I mentioned, this is definitely the first step, and it's definitely the first step that is, well, if not one of the most important parts of this. So thank you a lot for bringing this. And yes, you are very right. It is time for our questions. As you can see, we have a few questions ready. So let's get to this right away. And here's the first question. What do you consider irregular menstrual formula?
Okay, for example, as I said, like 2-3 days above down, this is completely normal. Irregular it will be, for example, if you had period the 10th of February and next one is 20th of March and the following one is
Dr. Emma, I'm sorry, the sound is breaking once more. Could you just try and switch it off and turn it back on, maybe? Cannot hear you still. If you can try to turn off the camera just once again, and let's try. Can you hear me? I'm afraid it's still breaking. Okay. All right, but we cannot hear you. Right now we cannot hear you. So please try to switch this off perhaps and let's refresh and hopefully it's going to be.
That, can you
Yes.
hear me now?
Yes, now it's good. We can hear you.
Okay, I did
Perfect.
several times.
Okay.
Okay, so did you hear me about the? Did you hear me the answer or no?
Not the whole answer, just the very beginning.
Okay, as I said, irregularity, it means that it doesn't follow any pattern. Okay, so the pattern can be, for example, every 25 days, this is regularity. Or if the patient has a period, sometimes every 28 days, some other time every 40, this is irregularity.
All right.
Has it
Perfect.
been
Understood.
understand, right? Okay.
Yes, of course. And of course, if you have any follow-ups, go ahead and type this in. But now it's all good. So I guess we need to leave it without the camera for now at least,
Okay.
okay? Now it's working, so hopefully it's going to stay that way. And let's have a look at the next question that we've got from Joanna. I missed the definition of the two types of infertility. Can't conceive, one, and second, can conceive not. No live birth as yet. How do you class name these to differentiate?
Okay, this is this differentiation we do it in Spain. Okay, this is I think is like more Latin. So, infertility is when you are able to conceive, but you are not able to have a live birth. In sterility is when you are not able to conceive at all. You haven't had any kind of pregnancy. Okay.
All right, perfect. Thank you so much for the clarification to this one. And Alex has asked, we have been trying for 2 years and have had 2 ectopic pregnancies. Does having an ectopic pregnancy count as infertile within 12 months?
Yes.
Okay.
Yes, it has been.
I'm sorry, Dr. Emma. Again, the sound is breaking, so we will need to refresh once more.
Refreshing. Can you hear me
Yeah.
now?
Yes. Now it's all
Okay.
good again.
Okay. Yes, it counts. Okay, as infertile. The most important thing is those two ectopic pregnancies had been in the same tube, because if they have been in the same tube.
Dr. Emma, sorry. Again, we lost you. Cannot hear you right now. Let's
Can you
wait.
hear me now? Can you hear me now?
Yes, again, it's good. Okay.
So, did you hear my explanation or no?
Not the whole thing again, okay? So please, you started, but we didn't hear the...
Okay, so what I was saying is that we count this as infertile, right? But the most important thing is if those ectopic pregnancies were in the same tube or not.
All right. Alex, if
Okay,
you have not, okay?
they say it's different tubes, right? Okay, so you
Yes.
can try. You can try for yes, not yes. That what that means. It means that in the same tube.
Sorry, sorry,
Not
not
in
in
the
the
same,
same tubes.
same
Okay.
tube.
Perfect.
Okay, so okay, in that case, maybe I would recommend you try for 6 more months, and if not, not longer, not longer. It depends also
Okay.
on the age, but not more than 6 months. And if if it doesn't happen naturally, then I will visit fertility doctor.
All right. Thank you. And there is a follow-up again. If same tubes, what would this mean?
That tube doesn't work. So if you know that if you have an ectopic pregnancy, you have more risk of having another ectopic pregnancy.
Sorry, Dr. Emma. Once more, I'm afraid we did not.
Apologize for you all, but I mean, can you hear
It
me now?
happens. It was all going great, okay? So don't worry. Of course, these things can happen. But there's a thank you from Alex for you as well for answering, and it's also from Joanna, previous patient. Okay, Infertility. Thank you for confirming. And also, let's have a look at the next question that we've got. So, do you also request DNA fragmentation analysis in sperm samples? Dr. Emma, can you hear me now? Again, it's breaking. Okay, so please try again.
Can you hear me now?
Yes, now it's okay. But we didn't hear
Hi, I
the.
cannot hear you now.
You can hear me now?
Okay.
Okay, just give us a second. Okay, we will try to.
Now, can you
I
hear
can
me?
hear you. I can hear you.
Now, yes.
Okay.
Okay. What I was saying is that I didn't recommend it every patient, right? It depends on the DNA fragmentation. It is supposed to be recommended in patients where in the sperm test you can see like less than 4% of normal sperm.
All right, understood. Thank you so much. And Joanna also has added, so we have been trying for 3 years, but when trying actively, conceived twice, miscarriage and ectopic. Should we just keep trying or should I go for full fertility checkup?
Okay, the most important thing is what do you understand with trying actively? Okay, because some patients they get it wrong when they think that, for example, they have been not using any kind of method for 5 years, but in the last year is when they really wanted to have a baby. So they think they have been only 1 year trying to conceive, but no, they're wrong. They have been trying to conceive for 5 years. It makes sense what I'm saying?
Yes, it does to me, of course. So, okay, let's have a look. There is Joanna has added tracking my cycle really regularly, I guess.
Okay, so no, you
Yes.
should go, then you should go to the fertility doctor. You should go to the fertility doctor because if you have had like 3 years with unprotected sexual intercourse, even though you were not concerned about your cycles, okay, not thinking that when you were ovulating and you haven't had any baby, like live birth, then I would recommend you to go and visit the fertility doctor.
All right. Thank you once again for that advice. Let's go back to the question from Joanna. So, if we know one tube does not work, how can we progress with only the correct tube?
There is no silly question.
Exactly.
So,
True.
so no apologies because sometimes I also make some questions. Okay, because with one is enough. Okay, sometimes you can see that the patient ovulated in the right ovary and she got pregnant with the left tube. So nature is really smart, and with one tube is enough.
Perfect. And thank you from Joanna for you as well. So let's have a look. There are like two questions left. We will be slowly finishing. So if you have any left, go ahead and type those in right now. And the question is, so do you recommend to do REM to the sperm samples all the cases before the treatment of fertility?
It depends. Okay. If we are thinking of IUI, sure. Okay. REM, it will give us also more information, but if you are going to go directly to IVF, I think it's not necessary. Because REM, you do it when you are thinking of intrauterine insemination, not when you are thinking of in vitro. It makes sense?
All right. Again, thank you so much for explaining that one as well. Now we will go to a bit of a longer question. And of course, Anna, if you have any follow ups, go ahead and type those in. And the question is, so we have had two IVF, ICSI, PGT cycles and unsuccessful both times, no pregnancy. Our doctor didn't find any reason both times for failure. He just asked that we try again in this situation. Are there new recommended steps going forward before we embark on a new IVF journey, as we just don't want to keep repeating the same thing?
Okay, I'm sorry for that. I would like to tell you that the success rate is 100%, but it's not true. Okay, so even with PGT, sometimes the rate of success is like 60-70%. Okay, yes, there are some things that we can do, for example, but I'm sure that your doctor did everything. Okay, you can use corticoids, you can use intralipids. So there are some therapies that you can add in the following IVF. The most important, I mean,
Dr. Emma, please just refresh once more, okay? Seems that it helps and it was breaking again.
okay, now
Yep, now it's again all good.
did you hear anything, or should I start again?
No, we just heard the very first like one sentence of it, so so
Okay, so I have to start again. Okay, don't worry. What I was saying is that IVF, when you do the PGT, okay, the success rate is like 60-70%. So it's not 100%. We wish, but it's not. Okay, so we can do some things to improve the quality of the transfer, as using intralipids, corticoids. Sometimes we use also heparin, but the most important thing I would say is the patient to be relaxed and positive, because that works a lot.
all right. Again, thank you so much. And it is true that sometimes if we are not having too much stress, then it definitely does make a difference. So yep, thank you so much for that. Someone is typing. I definitely want to wait and see if we do have another question, but of course, as I've mentioned, we will be slowly finishing. But of course, if you would like to ask some more questions, remember that you will be redirected to the site with the profile, Dr. Emma's profile. And if you would like to get in touch with her and her team at Vistahermosa, I'm sure they will be more than happy to help you out as well. And well, we will be finishing, Dr. Emma. I'm sorry, there's one more question that I
Okay, don't
just
worry.
this. So, if we can conceive naturally but no live birth, should we look at IVF?
Yes, if you remember, in the slides of I was talking about the female, in the part of the female, I was talking about a specific blood test for infertility. Okay, because we have to check, for example, in this case, if we had, for example, an autoimmune disorder, if you have a thrombophilia, or any of you are a carrier of a disease that is not allowing you to have a live birth.
All right. Again, thank you indeed for yet another question, Joanna, and of course for helping out as well. Dr. Emma, I believe we will be finishing, and as I can see, there are thank yous coming up your way. And thank you very much indeed. And more thanks are coming up. So, again, I would like to thank you, each and every one of you, for joining us tonight, for your patience as well. We had some technical issues, but I'm sure that it was still very useful for you. And those were like only minor issues. And we were able to hear Dr. Emma anyway. So, again, thank you so much. And Dr. Emma, before I let you go, anything else you would like to add?
No, thank you. Thank you for inviting me. And I hope that my presentation was clear enough and helpful.
It definitely was helpful. Lots of new information. for us as well, for sure. So thank you so much. And as you can see, again, very informative presentation. You see it for yourself. So thanks a lot for
Thank
that.
you.
And remember, it has been recorded. So of course, you will have a chance to watch this again. You will find it on my IVF Answers. And as you know, we will be back here tomorrow. Dr. Emma, if you can just perhaps try and switch on the camera, so just to wave to our patients. Once again, we can see you. Perfect. Thank you so much indeed.
Thank you.
And thank you for being also patient, because it is definitely late for you. So thank you.
Yes, a little bit.
Yeah, it's 1 a.m., right?
Yes, 1 a.m.
So yeah, it's definitely time to relax, and to all of our patients, have a lovely evening, and I hope to see you tomorrow at 8 p.m. Yes, amazing. I agree, Joanna. This is crazy, but I'm glad that we are able to still do it. Thank you so much, Dr. Emma.
Thank
And
you. Have a
take
good
care.
day.
Bye.
Bye. Bye.